My name is Brian Wilcock. I'm going to be your tour guide to the surgical pathology of the intestinal tract of dogs and cats. It might sound like an unusual topic, but in reality, private practice in veterinary medicine, at least in North America, now is dominated really by endoscopic examination of the gastrointestinal tract. It departs substantially from what we'd expect to see with post-mortem pathology of the canine or feline gastrointestinal tract. The diseases may be the same, but obviously the view that we get of them via endoscopic sampling is different. I'm not going to show you examples of every single possible disease because that would be repetitive, and in realistic terms we rarely, for example, would get an endoscopic sample from a parvoviral enteritis or from something like Salmonellosis. So I'm going to show you a biased sampling of the day-to-day accessions that would come into a busy surgical pathology business such as I have. And I will give you my opinion on what some of these lesions are. We do have a problem, all of us share this problem, that we do not get a lot of follow-up information about whether our opinion is correct or not. We continue to struggle, for example, with the definition of inflammatory bowel disease and how many leukocytes is normal and how many is not. And the research is frankly not being done to resolve that. So let's go to the slides and we will scamper through stomach and small intestine and colon, mostly with endoscopic samples, although with a scattering of full thickness intestinal biopsies. All of the slides are from biopsy material, none of it will be from necropsy material. This slide shows you what endoscopic biopsies look like in a gross format. These are what I'd call large biopsies, and they're also fewer than normal. The usual sampling from a gastrointestinal series in a dog or a cat would be 25 or 30 samples, scattered through stomach, proximal small intestine, colon, and if we're lucky, a few samples from ileum, depending on the size of the animal and the instrumentation used. It's recommended, by the way, that when one is going to do endoscopic sampling, that you take samples from all accessible portions of the gut. Even though the clinical signs may be exclusively gastric or exclusively colonic, there will sometimes be valuable lesions to be found in these other portions, which will help to solidify your diagnostic decision making. This would be a very good quality, perhaps unusually large gastric sample. It's not common that we would get such a good bite through the muscularis mucosae. So that's your muscularis mucosa there, and depending on the instrumentation, many samples will not be able to reach that deeply. But this is no different than looking at a large wedge resection or even a post-mortem sample, except of course it's considerably smaller. When we look at stomach, the background presumptions we make are that the normal fundic stomach shown here is basically wall-to-wall glands. There's very little intervening lamina propria that's visible to you, and there's not much loose lamina propria up below the surface epithelium. Leukocytes of any type are extremely infrequent in the normal canine or feline stomach. Here's one with which I'd have some difficulty. This could be normal. We don't really have a good concept of the range of normal. We all have a subjective opinion, but it gets a little gray and fuzzy at the edges. The surface epithelium is certainly normal. The glandular mass appears normal. One might debate whether there's just a little bit of glandular separation by edema and maybe just a little bit of edema with activation of fibroblasts in the superficial lamina propria. Depending upon the clinical circumstances and the clinical history, I may or may not choose to comment on this lesion as being anything approaching abnormal. When you go to the deep side of the biopsy, another area with which we have some trouble grappling is the amount of fibrous tissue that is normal between the base of the crypts and the muscularis mucosae. In dogs, it is quite a scant collection of collagen, but in cats, it can be very abundant. It is one of the changes we see with post-inflammatory gastric mucosal atrophy, and yet it is also, to some extent, normal. And so the debate about how much of this separation by collagen is one allowed to have before one is required to call it abnormal. I have no answer for that. I have no particular number to give you. This one, for a cat, I would consider normal. For a dog, this distance and this amount of collagen would be excessive. We assume that it is the result of edema and stimulation of fibroblasts as a consequence of previous inflammatory disease. We also have the problem of not knowing how long this will last. Even if I were to decide in my own mind and for myself that this is excessive, I still must make the next step, and that is to judge whether it has anything to do with the current clinical disease. If this fibrosis is extremely durable and lasts for literally years after a bout of gastritis, then it loses most of its diagnostic utility because we have no way of judging whether this lesion has anything to do with the current clinical signs. Here we have the first of our unequivocal lesions. There's a lot of equivocation goes on with endoscopic samples because we have great difficulty with the ranges of normal, which remain undefined. This is gastric mucosal edema, and this is seen in almost any animal that has hyperproteinemia. Gastric edema in dogs and cats at least seems to be a very sensitive indicator of hyperproteinemia. So this is not the cause, this is simply the result of a protein-losing enteropathy or perhaps a glomerular disease with protein loss. Another non-specific but very common lesion is gastric mucosal atrophy. Remember the first slide I showed you of stomach, I commented on the notion of wall-to-wall glands. If you look at the distance here from the muscularis mucosae to the surface, this is a markedly thinned gastric mucosa, and the glands exist in multiple nests separated by fibrous tissue. Just like in a uterine biopsy, we call this glandular nesting. We assume that this is a hyperplastic cluster originating from a little bit of gland that survived some previous destructive inflammatory disease. You can see residual leukocytes through here, but this is an old lesion. What we'd say about this is gastric mucosal atrophy, in particular glandular atrophy with some regenerative nodular hyperplasia or glandular nesting, and comment that the active disease was probably several weeks ago, if not longer. If asked for a prognosis, you should say that the intestinal tract in general, and in this case the stomach in particular, has remarkable regenerative capacities, and if you sample this a year from now, the odds are you would see a perfectly normal looking stomach. At the opposite end, this is the appearance of idiopathic gastric mucosal hypertrophy. This is usually a pyloric lesion, and what you see is an accentuation, a thickening, a hyperplasia of the outer half of the gastric mucosa. These are the cells of the gastric pits and the surface epithelium, and they undergo, in this case, a somewhat disorganized papillary hyperplasia. In other examples, they simply form straight villus-like structures. These are not qualitatively abnormal. This is a full thickness biopsy to allow me to appreciate the massive thickening, but imagine if this were just an endoscopic sample. Your biopsy instrument would be able to grasp only the outer half of this, so you'd end up with a biopsy composed entirely of these somewhat jumbled gastric pits. And what would you do with it? If you're having a good day and all your neurons were working properly, you'd be able to say, aha, a normal fundic biopsy or a normal pyloric biopsy should give me some surface epithelium and at least some of the glands. The fact that no glands appear in your biopsy and the biopsy is of adequate size tells you that you've attempted to biopsy an abnormally thickened mucosa, and thus you are allowed and empowered to make the diagnosis of gastric mucosal hypertrophy. We do not know the cause. Some cases, but not all, are associated with chronic eosinophilic gastritis, and it's reasonable to think that the hyperplasia of this epithelium is a result of inflammatory mediators and wound healing growth factors, and it's a completely accidental bystander response. In other examples, we see no inflammation, and I have no idea what is stimulating the mucosal hypertrophy as we see here. Just incidentally, in case you're confused by the terminology, to remember that pyloric hypertrophy can be muscular, it can be mucosal, and it can be both. And I'm using the term hypertrophy in a gross context to mean a general thickening of the tissue, even though the mechanism is one of cellular hyperplasia. If we get into more traditional gastric lesions, here is a early repair phenomenon. This is a dog that ate irritating chemical ice melting salt. This is a military dog who I guess was a bit hyper and was busy eating ice melting material off the sidewalks and did this on a regular basis, and that chemical is irritating and caustic to the stomach, and you have had then ulceration with early sliding repair. There is nothing magical here. This is ordinary non-septic ulceration followed by epithelial sliding and hyperchromasia, as you would find in any wound healing phenomenon. The stomach does not have a large bacterial population, and ordinarily one does not see much of a suppurative inflammatory response to any opportunistic infection. The leukocytes here are decidedly infrequent. I expect within another day or two this would make a full recovery with no residual lesions until the next time the dog decides to overdose on ice salt. One of the continuing conundrums in dogs and cats is what to do about gastric overgrowth. These are hard to photograph, but these are clusters of spiral bacteria which are normally present in stomach but are not normally as easily seen as is present here. It is a purely subjective opinion that you can tell the practitioner, look, it's a normal looking stomach, or if you want, it's a stomach with just a wee bit of superficial fibrosis, but you know there are too many bugs visible on the surface. They're spiral organisms. I think it's very difficult using ordinary histology to distinguish pathogenic Helicobacter from the various non-pathogens that are almost identical in morphology. If desperate, the practitioner may choose to take that piece of information and treat for Helicobacter. You're aware that Helicobacter as yet has not been proven as a pathogen for the stomach of dogs and cats, that is domestic cats. Koch's postulates have not been fulfilled, and if one surveys stomachs, you will find that there are as many normal dogs with Helicobacter as there are vomiting dogs with Helicobacter. So as yet, this is an interesting observation to see what looks like apparent bacterial overgrowth. Whether it has any role in pathogenesis or not remains unproven. 95% at least of the gastric biopsies are done looking for gastritis. It's an animal with persistent, either continuous or episodic vomiting, and we do the endoscopy to get a dozen or so samples taken at random from the stomach. I'd emphasize the need for multiple samples. Unlike colitis, which usually is diffuse, gastritis is habitually patchy. It is common, out of a series of a dozen, to have half of them looking perfectly normal, another 3 or 4 that sort of have equivocal change, and only 1 or 2 with truly convincing lesions. If you are forced to give advice about a limited number of samples because they're going to be full thickness surgical biopsies, I would suggest you concentrate on pylorus. Sort of sample for sample, I think pyloric stomach is more likely to give you an answer than any other portion of stomach. The least useful is going to be the cardiac stomach. Here's an example in which this wall-to-wall glandular mass has clearly been diluted, separated by fibrosis. The normally cell-poor lamina propria is loaded with leukocytes. You'll notice again the surface is normal. It is uncommon in dogs and cats to have gastritis that has epithelial change in terms of the surface epithelium. If you look more closely, you can identify a whole range of leukocytes, and here we get into another crisis of nomenclature. How many eosinophils does it take to diagnose this as eosinophilic gastritis? When you look at published discussions of inflammatory bowel disease, including gastritis, the usual opinion is that lymphocytic plasmacytic disease is immeasurably more frequent than eosinophilic. It really depends on your philosophic perspective about how one names a lesion. From a kinetic perspective, if one were to examine the recruitment of leukocytes on an hourly basis, there is no question that seeing even 10% of these cells as eosinophils means that the short-lived eosinophil, which comes and goes so quickly, is going to be the most numerous cell being recruited on an hourly kinetic basis. The lymphocytes and plasma cells arrive in the tissue and stay for very long times. So that if you're dealing with chronic disease, of course it's going to be dominated by lymphocytes and plasma cells. That does not mean that they're the cells most appropriate for therapeutic targeting. Exactly the same logic applies to skin, where in chronic skin disease, even a small number of neutrophils or eosinophils is taken as more significant, usually, than a much larger number of lymphocytes and plasma cells. So take it for what it's worth. I will look at it. If I see more than just 1 or 2 eosinophils, I will have no hesitation in diagnosing eosinophilic gastritis and suggesting therapy appropriate to that diagnosis rather than just garden variety lymphocytic plasmacytic disease. If we move from the inflammatory disease, and again in stomach it's relatively easy because the normal number of leukocytes is very low. This will become more problematic in small intestine. But if we leave inflammatory disease for a moment, the next disease to consider is lymphoma. This is the most frequent gastric neoplasm of cats. In that species, gastric carcinoma is extremely rare and mast cell tumor is very infrequent. Lymphoma is a common disease. In a fully developed lesion like this, it presents no problem. There's obliteration of architecture, obliteration of crypts, of muscularis mucosae, and migration of the reaction into the submucosa, and it's all a monotypic population of hyperchromatic lymphocytes. You notice I'm making the diagnosis at low magnification. Not only do I not need to look at these more closely, but quite frankly, looking at them more closely with histology is usually not very helpful other than to confirm they're lymphocytes rather than mast cells. I don't think there's a good way to distinguish malignant lymphoma from severe lymphocytic inflammatory bowel disease by looking at the cells themselves. One uses architectural features to make the distinction. A variant of lymphoma, the equivalent of cutaneous mycosis fungoides. This is epitheliotropic lymphoma. There is fibrosis, but the leukocytic involvement is along the basement membrane zone of the epithelial cells themselves. There is blurring of the distinction between lamina propria and epithelium because of these hyperchromatic lymphocytes selectively targeting the epithelial basement membrane zone. So epitheliotropic lymphoma of the intestine, in this case found in stomach. It would not be surprising to find lesions throughout the intestinal tract. Just to remind me, to remind you that other tumors do exist, this is a mast cell tumor within the stomach. It can be easily mistaken for a lymphoma. Toluidine blue stain may not work very well in gastric or intestinal lymphomas, so you have to rely on other criteria, the presence of eosinophils, central nuclei, finely granular cytoplasm. Not a frequent lesion to see, but always it remains as the most plausible differential diagnosis if you're a little uncomfortable that a round cell tumor may not really be a lymphoma. This is your next choice. substantial disorganization of gastric architecture. Nowhere in here do we have normal cryptal architecture. Very hyperchromatic, very jumbled, disorganized, fibrosis. This is gastric carcinoma. I think, like everybody, I would be much happier to make the diagnosis with a full thickness biopsy that allowed me to see transmural invasion. It takes substantial courage to make this diagnosis with an endoscopic sample. Look for the destruction of architecture. The cells themselves may not be particularly atypical in cytologic features, but they will be growing as isolated pockets of cells without cryptal architecture in the middle of the fibrotic lamina propria. In other words, they will be invading across the basement membrane and will be little orphaned islands of tumor cells. If you're lucky, they will have enough cytologic atypia that you will have no difficulty. Here they are thrown together in disorganized clusters, still attempting to make some kind of glandular cryptal structure and still retaining mucus-producing capability. Nonetheless, one cannot mistake the marked anisokaryosis and anisocytosis in these cells. The same kind of philosophy applies to small intestine. The great debate to which there is no answer, despite many firmly held opinions, is how many leukocytes is normal. To be a little bit cynical, the fundamental principle underlying the diagnosis of inflammatory bowel disease is, I think there are too many leukocytes in the lamina propria. Since we do not know the normal range, nor the things that influence it, making a statement like that has absolutely no scientific basis, and I make it every day. Someone has to offer an opinion, so go with it. But don't fool yourself into thinking you've given anything more than your best opinion. I would look at this and I would call this perfectly normal. I personally have a broad and forgiving notion of the range of normal. I think it changes by breed, it changes by diet, and it certainly changes with age. If this were a 6-week-old puppy, I would be all excited and commenting on the excessive cellularity. You are allowed to have a few intraepithelial lymphocytes that are found within the superficial cytoplasm, not in the basal layer. These will be probably 70% plasma cells in the normal lamina propria. Whether there normally are eosinophils or not seems to be a bit debated. When you look at accounts in textbooks, some will list eosinophils and some will not. I think a small number is perfectly normal. If you have inflammation, you are supposed to have inflammatory edema and cells separating the crypts, not only from one another, but from the muscularis mucosae. We know that in the colonic mucosa, the normal colon has about 4 cell layers between the base of the crypt and the muscularis mucosae. To my knowledge, that has not been validated for the small intestine, but I use it anyway. It's as much as we have. This is often very rich in eosinophils, so having 4 or 5 cell layers thick of predominantly eosinophils is perfectly acceptable. It is not acceptable when those cells move up higher. So here we have an example where even for me, the number of, this power, let's just call them leukocytes, within the lamina propria is stretching the range of normal. I think it's in excess of normal, and the crypts are separated from one another. They should be crypt next to crypt next to crypt with very little intervening lamina propria. So I think this is more than it should be. It is almost impossible to judge villus atrophy in endoscopic samples because of unpredictable contraction and unpredictable plane of section. If you have villus fusion, that's another matter, but just shortening, I think, is a very precarious judgment on which to base any diagnosis. Again, we face substantial challenge in distinguishing lymphocytic inflammatory bowel disease from malignant lymphoma. If you have a full thickness sample, you can use transmural invasion and destruction as an ally in saying, no, this is lymphoma. Inflammatory bowel disease, be it lymphocytic or eosinophilic, is primarily a mucosal disease with very little submucosal reaction. Here, I think there's enough destruction and certainly enough invasion that I would anticipate at higher magnification that I would be looking at malignant lymphoma. Remember that in dogs it tends to be a fairly monotypic population, but in cats their lymphomas are often quite pleomorphic. So you need to be prepared to not have the uniform monotypic dark lymphocyte. If I have only an endoscopic sample and it's early lymphoma, and after all, let's face it, a lot of the time the biopsy is going to come from an animal with chronic diarrhea, chronic vomiting, anorexia, maybe some weight loss. You don't expect most of your samples to be coming with animals with massive advanced lymphoma. So we have to get used to dealing at that uncomfortable cusp of indecision. Are we dealing with lymphoma or inflammatory bowel disease? If you have invasion, fine, call it lymphoma. I think this is a valuable ally. If the infiltrate in the lamina propria is beginning to obscure the junction between lamina propria and epithelium, call it lymphoma. Call that lymphoma. If these are monotypic lymphocytes with very few plasma cells, think about lymphoma. If you have the two together, you're feeling a lot happier. Small intestine will also get epitheliotropic lymphoma, in which the cells are obscuring the junction between lamina propria and epithelium, but are quite selectively into that epithelium without having much of a presence, as yet at least, within the lamina propria itself. So an epitheliotropic lymphoma in the intestine. While this might be a very common post-mortem lesion in pigs and calves with viral enteropathy, this, in my experience, is not a common lesion to see in small animal gastrointestinal pathology. You can see the villus fusion, you can see the thin, sliding, hyperchromatic epithelium. Depending on the clinical circumstances, this would be a perfectly reasonable candidate for something like a coronaviral enteritis in a dog or in a cat. It is a diagnosis I make very infrequently, simply because those diseases are usually transient and insignificant and do not get submitted for endoscopic biopsy. I suspect this sample came from someone with a new endoscope and a burning desire to use it. An intriguing intestinal lesion in cats, as if we didn't have enough trouble. This is mid-zonal mucosal fibrosis. In cats that are, the cat biopsies at least, rather than the whole cat, submitted with a history of chronic diarrhea, with or without vomiting, I will see this lesion and nothing else. We can accentuate it with trichrome staining. It is a remarkably specific band of mature fibrosis that lies in a horizontal orientation at the crypt-villus junction. I am not alone in this opinion, but it is still just an opinion, that this is a reliable residual lesion of previously active inflammation, and probably predicts that the inflammation will flare up again. So what do you do with this? You say, look, it has fibrosis. I think it's a result of inflammation. It tells me that your hypothesis that the cat has chronic, ongoing, episodic inflammatory bowel disease has some merit. And that's about all you can really say. Does the lesion by itself have any functional significance to the gut? Surely it must somehow impair absorption, cause lymphangtasia. Answer, we simply don't know. If we speak of lymphangtasia for a moment, Lymphangtasia is not a difficult diagnosis if you have the right biopsy. If you have a full thickness biopsy and capture a serosal granuloma that is probably forming around a leaking lymphatic, this is a routine diagnosis. If you have a full thickness sample with massive villus lacteal dilation, dilation of lacteals even through the wall, it's an easy diagnosis. But if all you have is an endoscopic biopsy like this, you don't have the serosa, you don't have transmural lymphatic distension, all you've got are, let's say, half of the villi with a moderately distended lymphatic, what are you going to do? And I can't counsel you on that. I'll tell you what I do is I say it's got dilated lymphatics. If the clinical circumstances are right, this is supportive of lymphangtasia, but I do not make the diagnosis without lots of backup support. I think it is possible to induce this lesion as a biopsy artifact, especially when it's of modest proportion and seen in only, let's say, 30 or 40% of the lacteals. I think the opposite is also true, that I think if you have dilated lacteals, by the time you take this little sample, put it into formalin and shake it for a day or two on the courier truck, you can easily lose this lesion. So if someone calls me and says that they have a suspected lymphangtasia, how can they prove it? I would say give me a full thickness biopsy and describe for them what the serosal lesion, what the lymphangitis and perilymphatic granulomas would look like, so they can be directed to biopsy those in addition to a full thickness mucosal sample. In those samples, you will quite frequently find that the classical lacteal dilation pictured in all the textbooks is indeed an elusive lesion. Much more reliable and more comforting is the presence of dilated lymphatics at the level of the muscularis mucosae and in the submucosa. If I see these, I am quite content to make the diagnosis of lymphangtasia. In my experience, the lesion in the lacteals, wonderful if you get it, but it's not very reliable. Other lesions we might see. You'd look at this and say what we have is rather non-selective mucosal necrosis. It could be ischemia. It could perhaps be some kind of radiomimetic drug. In this case, this is probably parvovirus, be it dog or cat, with cryptal necrosis, collapse of villi, and non-selective necrosis in the absence of any substantial leukocytic infiltration. Lots of redness, lots of vascular inflammation, if you will, but not many leukocytes. Again, a valuable clue pointing to panleukopenia or parvovirus. Just as a little aside, when you do either gastric or small intestinal samples, you may find little bits of debris like this. There's a piece of hair, and this is yellow granular refractile material, and this is barium. Most of the biopsies I get are from animals that have already had a barium series, and so it's not surprising to pick it up. If you want to have some fun, you can become a student of the histologic appearance of Pepto-Bismol, X-Lax, Tums, and other things that owners might have administered to dogs or cats with vomiting. So that is barium. Another case looking a lot like parvoviral enteritis, villus collapse, cryptal necrosis, and perhaps a few early efforts at cryptal repair. I don't often get biopsies from parvoviral dogs or from cats, just because in the case of cats they're usually dead and I get the necropsy. In the case of dogs, the disease is usually so distinctive it is diagnosed by clinical means or by other testing and not by biopsy. These dogs are not usually good candidates for any kind of surgical intervention. Occasionally there'll be a dog that seems atypical, like an adult dog that's been vaccinated that has a lesion they has a disease they can't believe is parvo, and those I might get a surgical biopsy from and see the characteristic lesions. every once in a while there can be a surprise. This looks just like parvovirus, cryptal damage, early repair, nice dysplastic proliferating epithelium. I said this has got to be parvovirus, called up the clinic. The dog is fully vaccinated. The dog lives alone in an apartment, has very little contact with other dogs. It seems most unlikely the dog has parvo, but by the way, the dog has a splenic hemangiosarcoma and is being treated with adriamycin, which is, of course, an antimitotic drug. So this is a radiomimetic parvo-like lesion caused by a cancer drug. Would have been nice to have that history ahead of time, but it was nice to get it no matter what. Now here's a slide that might look like very much the same thing. A fair bit of cryptal damage, some villus collapse, some hyperplasia in an attempt to repair the surface, but there are a lot of leukocytes with this one, and you notice that there might be some submucosal involvement. Neutrophils, not visible at this magnification, are a prominent part of the reaction. You need to at least keep in mind that infectious disease is not entirely gone from the world of small animal intestinal pathology. This is salmonellosis in a cat. I used to think that salmonellosis in a cat was always acute, devastating, fatal disease. Not so. I've had a number of cases of at least subacute, week or two, of diarrhea in a cat that had lesions like this with a neutrophilic, non-selective, destructive enterocolitis that turned out to be salmonella positive on culture. So I think we still need to keep in mind some of the traditional bacterial diseases. I will say in general that histology is not particularly good for the diagnosis of things like Giardia and Campylobacter and so on. I think often they simply masquerade as yet another non-specific lymphocytic plasmacytic enteritis, maybe with a bit of villus atrophy. It's very difficult to identify, for example, Giardia in histologic sections, and I have little confidence in my ability, at least, to do that on any regular basis. Here's a devastating lesion of non-selective acute necrosis with extensive hemorrhage. This is an intestinal infarct. Sometimes there will be exploratory surgeries done, and believe it or not, we will not get a history that says there is an intussusception or a torsion. We'll simply get a biopsy and say, what is going on? And we look at this and say, surely this must be some kind of intestinal vascular accident. You will also see this, I must warn you, in intestinal obstructions, that if the pressure is high enough from an impacted hairball or other foreign body, you can get such high pressure that you will collapse the blood vessels within the mucosa and submucosa. Since the tunica muscularis is supplied by submucosal vessels coming off a large plexus in that location, damage in the submucosa will have consequences then that you will see as tunica muscularis necrosis. This particular case was in fact a hairball, not a torsion or intussusception. Another example of ischemic damage. This used to be a mucosa. The whole thing has simply collapsed. If you are lucky, you will get to see innumerable hairs embedded in the fibrin on the surface to give you a hint that this might be an impacted hairball. I am surprised at how frequently I will see severe, deep intestinal ischemic damage from impacted foreign objects, particularly hairballs in cats. Here's an interesting lesion. This is ileum, and yet it has a strange lesion here that is not easily recognized. When you go a little closer to it, lo and behold, you find that this looks like gastric mucosa with parietal cells next to intestinal crypts. This is gastric metaplasia within the ileum. It is a lesion that's been reported in the literature. It's in the textbooks. I have no idea as to its pathogenesis. I don't even know whether it has any clinical significance. It is simply an interesting finding when you see it. here's trouble. Here's a section of intestine that has a focal interruption in the form of a depressed ulcer, but emanating from that ulcer are these ugly cords of hyperchromatic epithelium. This, of course, is the familiar histology of small intestinal serous carcinoma. This is mostly a feline phenomenon. We'll also see it incidentally in goats and sheep, but that's not the focus of this particular talk. What's important about this is it's hardly ever recognized by the clinician as being neoplasia. It will look like an intestinal stricture. It is often segmental and circumferential, and the cat presents with clinical signs of intestinal obstruction. So be prepared for the diagnosis to come as a bit of a shock to the practitioner and, of course, to the owner. If you get a full thickness sample, sometimes what you will see is this within the tunica muscularis. There are times when, either because of poor trimming on the part of the pathology technician or the pathologist, or perhaps because of inappropriate surgical technique, all you have is the tunica muscularis. And what you will see is muscle replaced by lakes of what look like mucus. It will stain positive with PAS. And you say to yourself, how on earth can I get big lakes of mucus sitting within an otherwise normal appearing tunica muscularis? And the answer is you have a transmural mucinous intestinal carcinoma. This occurs in stomach, in small intestine, or in colon. I think it's useful to note the similarity. When we talk about intestinal carcinomas, I'm inclined to group gastric, colonic, and small intestinal as a group, because in terms of histologic phenotype and behavior, they are all the same. And that makes sense because, after all, the intestinal mucosa all has a common progenitor, and when neoplastic, it is not surprising they will all look and behave in a very similar fashion. It is frequent that you find only clusters of surprisingly well differentiated intestinal epithelial cells, a bit of a contrast between what looks like a well differentiated cytologic phenotype with abundant mucus production and yet a very malignant transmural invasive behavior. Surgical cure is virtually impossible. These tumors have already exfoliated into the peritoneal cavity by the time you make the diagnosis. There are many other tumors that will occasionally occur in the intestine, and you can look those up, but in fact your mind will be cluttered with rare things. A few of the common ones: Lyomyoma and Lyomyosarcoma are relatively frequent tumors in intestine. They're perhaps more common in the colon than elsewhere. They're also more dangerous in terms of metastatic disease. It's one of the tumors in which precise distinction between Lyomyoma and Lyomyosarcoma is difficult. It is a continuum. Arbitrarily, I will use mitotic index to distinguish. I do not expect Lyomyomas to have any mitotic figures. If I see more than the very occasional mitosis, I am going to call it Lyomyosarcoma. If I have things like anisokaryosis, hyperchromasia, and so on, that's a bonus. Remember that these may grow outwardly as fairly typical serosal lumps, but they may also choose to grow inwardly and cause obstructive intestinal masses with nothing visible from the outside of the intestine. They're also capable of causing paraneoplastic syndromes. Not an insignificant tumor. Intestine will develop mast cell tumor. They can be confused with lymphoma quite readily. Look for a few eosinophils, look for a slightly granular muddy cytoplasm, and for a nuclear configuration that is more open, more vesicular than would be true for the usual lymphoma. Here the mast cells are accompanied by eosinophils. This one is a giveaway. Let me assure you, they are not always that easy. If we move into the colon, and because instrumentation for biopsy in colon is much less expensive, you can go just with a rigid proctoscope and get quite useful colonic biopsies. Overall, you are expected to get more of these than you are of gastric and small intestinal biopsies, which do require expensive endoscopic equipment. The normal colonic mucosa has goblet cells from top to bottom, has very little visible lamina propria, so it's crypt next to crypt next to crypt. It has a modest lymphocytic plasmacytic resident population. It has no more than 4 layers of cells below the base of the crypt, between the crypt and the muscularis mucosae, but a lot of those will be eosinophils. Eosinophils do not belong in the upper 2/3. Mitotic figures are found only in the basilar half, not in the upper portion. A common lesion is colonic erosion. I worry sometimes that the erosion I see may just be iatrogenic. By the time these dogs have been poked and prodded often enough, it would not surprise me to have some shallow surface erosion. So I'm a little bit cautious if this is the only lesion that I have. One must be careful. But you can see here there's been loss of continuity. These are regenerating cells, a little bit bulbous, a little bit hyperchromatic. Over here, this is probably just artifact. This I'm not so sure. I like the regeneration. Remember that all parts of intestine regenerate very rapidly. This creates a bit of a problem when you consider the normal flow of material through a veterinary hospital. It is entirely conceivable that the animal that is deathly ill on the weekend will enter the hospital on Monday, be worked up on Tuesday, and be biopsied on Wednesday. That 3 or 4 day interval between the disease event and the biopsy is enough time to regenerate an entire colonic mucosa. The turnover time, depending on the age and diet and a few other things, is somewhere 3 to 5 days. So it repairs very, very rapidly. And I think sometimes by the time we get the biopsy, the lesion has actually almost disappeared. A lesion like this, for example, I would expect to heal within 12 hours. So it's an elusive thing. If the history is one of chronic diarrhea and all you see is this, you have every right to be skeptical that this lesion, which might be a thermometer or proctoscope or finger-induced lesion, has anything to do with the disease at all. I also distinguish, perhaps with no reason, between ulcerative colitis and colonic ulceration. Sometimes in dogs you will get, and in cats for that matter, you will get ulceration of the colon with remarkably little inflammation. Other times you'll have a robust inflammation, eosinophilic or lymphocytic plasmacytic, along with concurrent ulceration. I have no feedback from my clinical colleagues about whether they consider the distinction important, whether the dogs with just ulceration respond better or differently to therapy or require different therapies than do dogs with true ulcerative colitis. So I make the distinction. As in stomach and small intestine, I will look for eosinophils, and as I've said, I do not want to see eosinophils in the upper half of a colon. If they are there, I believe they're abnormal. If they constitute even 20% of the cells, I will consider them to be the dominant incoming cell and the appropriate target for therapeutic intervention. I would call this eosinophilic colitis. Lovely eosinophils below the base of the crypt, much in excess of the 4 cell layers that are considered acceptable. FIP causes a submucosal vasculitis, vascular necrosis, hemorrhage within the colon of cats. It can be seen as a colonic disease in the absence of any other clinical evidence of FIP. Beware that salmonellosis can sometimes do the same thing. The FIP vasculitis, no different in character than FIP anywhere else. histiocytic colitis in a boxer, a distinctive lesion, PAS-positive macrophages in almost pure population within the colonic lamina propria. Fatal disease, young boxers, French bulldogs, and a few other related breeds. The last disease that I will talk to you about is colonic adenomatous hyperplasia, known as carcinoma in situ. Confusing terminology. This is a non-malignant proliferative lesion that seems to start abruptly as a dysplastic change in otherwise normal cryptal epithelium, and it grows then as a jumbled, thickened layer of cytologically atypical cells. They extend onto the surface of colon to cause a papillary bleeding lesion, but they do not invade into the lamina propria, and they are not considered malignancies. True invasive carcinoma of the distal colon of dogs is extremely rare. This is the lesion one will see, and it should not be considered a malignancy. And last, colonic plasmacytoma. Unlike plasmacytomas elsewhere, this one has the potential to be invasive, to go to local nodes, and very rarely to metastasize. Beware. I'm not sure what percentage are truly malignant, but a few of them are, and I would be cautious.